So, good evening, everyone, and namaste, vanakkam, and welcome to all of you. And I'm so excited about this learning series because every series seems to be getting a lot of attraction, though it is at 7 p.m. in the evening. So that is really fantastic. Thank you, everyone, for joining here. Before I hand over the platform to our speakers today, just give me a moment. I will say a few things and then we will move on. This makes few announcements. Please confirm you can see my session slide. Yep.
Yes, ma'am.
Okay,
Yes.
great. So these are our monthly learning sessions being, hosted by our patient safety fellows. And patient safety fellowship, as you all know, it's a flagship initiative by ANEI in collaboration with Patient Safety Movement Foundation USA. And this is our, three cohorts are in place. The first cohort graduated, second cohort will graduate this year. And this year, this all these learning series are being brought to you by cohort three in attendance with their mentors who are ex-fellows. So this year we are focusing on actionable evidence-based practices. May I request everyone to mute their system, please? Thank you. So this is the entire calendar we had promised, and we are now sitting in August, and the topic this time is severe hypoglycemia, to be presented by Karishma and supported by Dr. Bijaya Tongam. So evidence-based practice is actually a process to review, analyze, and translate the latest scientific evidence. Now we know that all the knowledge that we had maybe 2 years ago, 3 years ago, can be revised because there is a whole lot of research happening elsewhere in our country, not in our country, outside the world, outside our country, in the world. So we need to bring that back to India and share that knowledge with everyone so that we are doing our evidence-based nursing practice based on available evidence. That does not tell that we cannot find our own evidence for that. We have to follow process to say this is the evidence that we got in our country, but there are not too many publications around that. Yep. So, one announcement for all of you is that we are inviting each and every one of you for our ANEI annual patient safety conference, APSI 2024, on 27th of September in MS Ramaiah College of Nursing. So, and also we are inviting ANEI members to apply for the next cohort of ANEI Patient Safety Fellows. So the information is available on our website. So this month we are going to discuss about severe hypoglycemia to be presented by Karishma, ANEI Patient Safety Fellow 2023-2025. And she is the ANS with Apollo in Assam. And Dr. Bijaya Tonkam is, principal, College of Nursing in Kolkata. So we have different senior people, nurses, investing their time to undergo the fellowship program and then ensuring that it is being shared by others. So next month in September, we are going to talk about early mobility management. Now, this is a new focus area that is emerging, that why early mobilization is important for patients to have their prognosis made better, to be presented by Jyoti Gancheria and Ishita Chanta. She's cohort 3 and Ishita is from cohort 1. So that's how we are complementing each other. So with that, I will say thank you to everyone, and I also say thank you to both Karishma and Bijaya. Thank you for investing time to study on the topic, and you are going to share this with lot many sitting here and lot many who would watch the recording. And so we already have 130. Thank you, everyone. That's a good number to start with. Huh? So it must be the attraction of Dr. Bijaya and Miss Karishma, I should say. So I would now hand over the platform to both of you to do the Karishma of severe hypoglycemia. Okay, over to you, Karishma and Bijaya, and all the best. I am right here, and if there is something, I'll pitch in. Otherwise, you will not hear me or see me till you complete. Okay, and we are 7:06, and we have time till 8 or 8:05. It's okay. Let's see. We will take the questions, ladies and gentlemen, at the end of the session. And around 8 o'clock, Dr. Bijay is going to share the link for you to fill up the form, and then you can get your e-certificate on your email. With that, over to you, Karishma and Bijaya. Thank you.
Thank you so much, ma'am. It is because of you everything is happening, ma'am. It is a great privilege and honor to be here in this any platform, and under any umbrella. It is another great platform, that is the Patient Safety Foundation USA. So we'll try to do our justice today on severe hypoglycemia. So let us take some moment to share our slides, and Ma'am Bijaya will start the session.
Okay, thank you, ma'am. Thank you, ma'am, for giving me this opportunity, and Karishma for introducing. So now I think it's 7 o'clock here in Northeast. I think majority of you, the time is for dinner. I hope everyone is not hungry now.
Not yet. That's why they are all here.
Ma'am, for us Northeast, we used to eat by 7:38. Some people eat by 6. So today, we are going to see whether you are going to have hypoglycemia based on what I'm going to explain today. Okay, but the real topic is on severe hypoglycemia. This topic is basically for the clinical, especially in the ICU, for those people who are diabetes. But now let's see what is severe hypoglycemia. Karishma, please. Okay, coming to the introduction. Now, we all know what is hypoglycemia, but today, severe hypoglycemia, we are going to discuss on this topic. So when you tell about severe hypoglycemia, it is an event where you need another person in order to administer either the carbohydrates, or it can be glucagon, or it can be any other corrective actions, where basically it can be the administration of the IV dextrose, or it can be administration of 5% dextrose or 50% dextrose. So if you see the sugar level during that time, you can see that the blood sugar drops to below 50 milligram per deciliter. So this is the time we call it as a severe hypoglycemia. But in case if you have not given the corrective measures, this severe hypoglycemia will cause harm to the patient in the hospital setting. And at the same time, this also will cause morbidity and sometimes occasionally mortality in the hospital. Now coming to the classification of hypoglycemia. I have already told you you all have hypoglycemia, but here we have 3 hypoglycemia: the mild hypoglycemia, the moderate, as well as the severe hypoglycemia. So when you tell about the mild hypoglycemia, this is the time when your blood sugar drops below 70 milligram per deciliter. But I think this one, everyone would have experienced when you are so hungry, especially when you do not have your breakfast and then you go to the clinic. So let's see what is the symptoms. So when you tell about the symptoms, this is basically you will have autonomic symptoms. So when I tell autonomic symptoms, it is basically your palpitations, your tremor, your diaphoresis, your anxiety, your paresthesia, and sensation of hunger. Karishma, the previous slide, please. So that is what we call it as the autonomic symptoms. I think all these symptoms, what I have explained now, that is the tremor, the anxiety, the hunger, all these are present when you have hypoglycemia. But what happens to this? When during that time, you as an individual, you'll be able to treat yourself. But in the second category, that is the moderate hypoglycemia, where your blood sugar will be below 55 milligram per deciliter. During this time, you have 2 symptoms now: the autonomic, which you had in your mild hypoglycemia, and then you have another type of symptoms, which is neuroglycopenic symptoms. So this neuroglycopenic symptoms is nothing but this is the symptoms which are manifested when you have a low glucose level in the brain. So during this time, you have symptoms which we will be discussing in the next slide. But still then you will be able to treat by yourself. But both this mild hypoglycemia and moderate hypoglycemia symptoms will depend on the threshold of your tolerance of that sugar level. Now, the third one which we are going to discuss is the severe hypoglycemia, which I have already explained. It is the hypoglycemia when your blood sugar level is below 40 milligram, and at the same time you need a person in order to give the treatment or corrective measures, and then most of the people will be unconscious this time. So the next is the signs and symptoms, which I have already explained, but we will see again the neuroglycopenic symptoms again. So in neuroglycopenic symptoms, which I have already mentioned, when does these symptoms arises? These symptoms arises or manifested when your blood glucose level is low in the brain. So that time you can see what are those symptoms. There are lack of concentration. The person will not be able to concentrate. The patient may also will have headache. Then you will have blur vision, dizziness, confusion, convulsion, speech disturbance, restless, and loss of consciousness. So sometimes these symptoms can be identified even in the patient before they go to the severe hypoglycemia. So we need to have a look on the patients on these symptoms before you or before the patient goes into severe hypoglycemia. So the next slide is the prevalence of hypoglycemia. So when you tell about the prevalence of hypoglycemia, let us see about the India first. So according to the survey which was done by the National Family Health Survey 5, which was done in 2019 to 2021, it shows that around 6.1% of the women and 7.3% of the male were having blood sugar in the range of 141 to 160 milligram per deciliter. Similarly, a similar range is also seen with the blood sugar more than 160 milligram per deciliter. However, when you see about severe hypoglycemia, we can see that in type 1 diabetes mellitus, the severe hypoglycemia usually occurs 35 to 57.44%. That means out of 1 out of 10, at least 5 of them have got severe hypoglycemia if you are a type 1 diabetes mellitus patient. Then it was also shown that the higher the duration the patient is suffering, that means if you have a patient who had suffered more than 15 years of diabetes, the chances of getting hypoglycemic is severe hypoglycemic is as high as 46%. Then those people who have less than 5 years, where the percentage is 22%. Then coming back to the insulin treated type 2 diabetes mellitus, it was also reported that every patient will have hypoglycemic in where the prevalence is around 16.5%. Then it was also seen that if a patient has got severe hypoglycemic attack, the length of the hospital stay is longer. Usually it is longer by 6 to 10 days. So the next slide is on causes of hypoglycemia. So I request Karishma to do the further explanation. Thank you.
Thank you, ma'am, for initiating such an important topic, as ma'am said, severe hypoglycemia, which is a patient safety events, patient safety concern for all of us. There are 219 and 220 participants with us in this platform today in ANEI. And I'm hopeful that after we discussed today about severe hypoglycemia, everyone will go home with some take-home messages, and we can prevent hypoglycemia. So when we have already learned about hypoglycemia, severe hypoglycemia, we have also seen the classification of hypoglycemia as well as prevalence, how serious the concern is. So let us discuss about causes of hypoglycemia now. I hope the participants who have joined here have already come across, many causes which which cause hypoglycemia. May I request all the participants to in the chat box what cause you come across or how you could have managed the hypoglycemia. I request everyone to put in the chat box what are the causes you have come across in your career which can cause hypoglycemia or which already you had experience, so that we can learn from each other through this webinar. All right. So when we discuss about causes, there are mainly two broad classification. One is exogenous and one is endogenous. However, we have classified or we have outlined few causes which are very, very common and we come across in our day-to-day practice. The first causes highlighted is pharmacological causes. Yes, different studies, research studies, as well as the Patient Safety Foundation guideline has, mentioned that drugs are the most common cause which can cause hypoglycemia in patients. When we talk about drugs, actually we use the drugs as a therapeutic intervention mainly for treating diabetes. However, these drugs, mainly sulfonylureas, insulins, and when we are talking about sulfonylureas, most commonly metformin, glipizide. These are the drugs which are very, very at risk to cause hypoglycemia. Other than this category, there are different drugs like ACE inhibitors, beta blockers can also cause hypoglycemia in patients. That is the reason it is very, very important for a nurse, for us to know all the drug action. If these drugs are administered and we are going to administer to the patients, we also need to take care of the hypoglycemia events in our mind. Moving ahead, another reason is cortisol deficiency. We all know that cortisol is a hormone which is being produced by adrenal gland, and the cortisol hormone helps us to convert the food into energy, which is a much requirement for us to go ahead in day-to-day activity. However, whenever any disease of the adrenal gland, such as adrenal insufficiency, addition disease, these are happening with the patient, there will be low cortisol produced by this gland. Whenever there will be low cortisol production by this gland, it leads to a decrease glucose production by the liver, and it again leads to decreased glucose uptake by the peripheral tissues, which lead to hypoglycemia. It is very, very important again to know about this cause. Why? Whenever we send a blood investigation for patients to rule out cortisol deficiency, if we are much careful about this report, it can also give us an alarm that my patient might go for hypoglycemia, so I can take all the necessary actions when I have time. Another very important cause is malnourishment. Yes, when we are talking about malnourishment as well as nutritional deficiency, it can also directly cause hypoglycemia. So what happened when we fast? Actually, many of us used to fast, yes or no? So when we fast, there is already a store of glucose in our body, which is called glycogen. It is being used up by body to release the energy. However, when there is lack of food or some nutritional deficiency occur, then the store of glycogen is already used up. And when there is lack of food, it will inhibit all the manifestation of hypoglycemia. When we are talking about vitamin C deficiency, it also induces hypoglycemia, and vitamin B12 deficiency, which can also cause one very, very dangerous sign, that is hypoglycemia unawareness, which we are going to discuss in upcoming slides. Another cause is intake of alcohol. Yes. So it is not about those person who use occasionally one or two drink, but whenever any person is used to or habituated with the alcohol intake, then it might cause severe hypoglycemic event, because alcohol inhibits the gluconeogenesis process along with depletion of the glycogen store. Alcohol also indirectly increase endogenous insulin secretion. And what happens is, why we need to know about this is, whenever person is alcohol intoxicated already, person might manifest the similar signs and symptoms of hypoglycemia, which is why the person or the caregiver of the patient might ignore or neglect the signs and symptoms. They might think it is because of alcohol intoxication, whereas it might be because of hypoglycemia also, which is very, very important to know. Very another cause is critical illness. Critical illness, like as you all know, it might be end-stage renal disease, it might be liver failure, it might be sepsis, it might be related to all the vital organs with us. So what it does is it stimulates there will be increased uses of glucose utilization, and also it limits endogenous glucose production. And whenever patient is critically ill, there will be definitely inadequate nutrition supply to the patient, and all comorbidities like hypertension, diabetes will be already linked to the patient critical illness, and which in turn we have seen that in the critical care area, there might be intensive insulin therapy. Different research studies has proved that the most hypoglycemic
Karishma? Power failure? Maybe, ma'am. Power failure might be.
and which might lead to hypoglycemia. Ma'am? Am I audible?
Yes, Karishma.
Yes. So another cause to list it is here, patient food intake. Yes, it is very, very important that what, when, and how much patient eat food. So,
Karishma, are you there?
there.
Karishma, maybe you can stop your video and continue talking because your voice is getting lost.
Okay, ma'am.
Connectivity is okay there?
Yes, ma'am.
Yeah, continue to talk.
Is it- so what we were discussing about patient food intake. Yes, how much, when, and what patient is eating, it matters a lot if patient is already diagnosed as a diabetic. So I would like to request Sangam ma'am here to share your experience of causes of hypoglycemia, as we have already discussed 6 causes here.
So,
Ma'am.
yeah, thank you. Thank you, Karishma. Hmm. I'm just having a little bit of cough, so I hope I will not cough when I'm talking. So I'm going to talk about some things that I have seen. A lot of answers are coming in the chat box, which says related to, patient fasting, patient not eating, patient not, patient on, nil per mouth, like NPOs, So I think you got the most common reason, which is related to eating, fasting, and then patient going into hypoglycemia. Now, a couple of things what I want to highlight from my own experience is that many times nurses tend to carry out orders without paying much attention to what they are carrying out. Whether they are giving insulin or whether they are giving anti-diabetic drugs, what is the patient's base level diagnosis, what is the patient's blood sugar to start with. The question always remains that you have given insulin to the patient, because there is order to give insulin before lunch or before dinner or before breakfast. You went and gave the insulin. And after that, you did not go back and check if the patient had his meal or not. So many times when I had experienced or when hypoglycemia was reported, it was mostly related. One, the patient received the insulin but did not take the food well, and no one knew about it because the nurse did not go and check whether the patient had his meal or not. So, at least that there is a risk for this patient to have hypoglycemia. That did not happen. Or the patient, we knew the patient is not going to eat, but somehow the nurse went and gave the insulin. So it was again bound to happen, right? And also knowing that the patient is diabetic, many times the doctors will remember to start, dextrose IV if they are diabetic on insulin, they are fasting for a procedure or for surgery. So they do start, dextrose just as a backup, so that they don't get into hypoglycemia. Now, these are the areas in which the nurses can be aware, and they can even, remind to the doctors, that this is how it is, and then there are, drugs which can interact. So in nutshell, I don't want to go on and on. My request to all the nurses sitting here, all the nurses who are going to watch this recording, is that please know your patient. So a little while ago, Dr. Bijaya mentioned about, hypoglycemia, mild and moderate and severe. Now, these are literature evidence which is available. This is talking about the larger, commonly this is what it is. But there can be aberrations. Every number is unique to a particular patient. I will give you my own story. I am pre-diabetic. Okay, so my uh, fasting went to about 118, 120, and the doctor said we will start on a very mild dose of metformin, 500 milligrams, only once a day. I started, and I started feeling low. I could feel that I am going hypo. And then I reduced it. I said, oh, metformin too much, 250. Again, my body was not taking that medicine. My sugar was again going down. And the interesting part is not that the sugar was going down. When was I feeling the symptoms of hypoglycemia? I feel weak. I feel as though my, stomach has become totally empty, as though, I want to eat so many things. And then I can feel a bit dizzy. I can feel that it's not feeling normal. And I checked my blood sugar every time when I had that symptom. And you will not believe me, friends who are here. It is not 50, it is not 40, it is not 70. It was always 80. So, what it means, my body cannot take any sugar, sugar level of 80 and below. When it hits 80, now without checking, I know that my blood sugar is 80. I don't take any medicines, but if I don't eat well, or if I don't eat in time, I can feel that, I usually call it as I feel whooshy. Whooshy, I don't know from where the word is. It just means I'm feeling little dizzy, I'm not feeling good, and I'm feeling very empty in my stomach. And that's how I feel. Now, do you know how your patients will behave? So what is very important is to know your patient. Patient A and patient B with same diagnosis will not mean they can be treated the same way. How will you know the difference? How will the doctor know the difference? Only when a smart nurse is able to understand the subtle changes that happens in the patient. So I will rest my case. All these things, you can learn. Most important, how do I put that into my practice? When it comes to ICU, that's a different story altogether, where patients, because under stress, they do become hyperglycemic. Then that's a different challenge, that how do you treat? One more thing, hyperglycemia can seldom kill the patient, but hypoglycemia can kill the patient. If there is time, I will tell you a very, very sad story towards the end of the session, which is related to, you know, insulin and hypoglycemia and what happened to a patient. It's a very sad story, happened abroad when I was working in Saudi. I will share the story because I'll never forget these patients. Over to you, Karishma and Bijaya. I can go on and on, so let me stop here, and I will request you to continue with what you are sharing with all of them. I'll come back with the story towards the end.
Thank you so much, ma'am, for sharing your stories, and we are going to listen to you many more, I think, when we at the end of the session. To mention here, I have just gone through different kind of literature, and I have seen that one systematic review where it was published that there are 448 publications where it was mentioned that drugs are the most common cause to induce hypoglycemia. So as nurses, our prime responsibility is medication administration and the safety of the patient. So I think we need to consider all those things. Thank you so much to everyone for putting in the chat box all the reasons which I'm going to tell now. Like definitely somebody has mentioned, if we are failing to monitor blood sugar level at specific time and the stipulated time of the patients before meal or uh, go on. Another one is timing issues, inappropriate timing of insulin. So we have specific timing of insulin as per the types of insulin. If we are not following that, or if there is inappropriate timing, then it might be causing hypoglycemia, which is a very, very danger. And one, uses of different types of insulin. One patient might be getting two types of insulin, like patient might getting one rapid acting and as well as long acting insulin. So if you are again not aware of this, not maintaining the time, which is again can be co-factored by failure to monitor blood sugar level or inappropriate timing of insulin, it can also lead to glycemia. I hope all the audience by seeing this picture will understand that I'm talking about ineffective communications. Just to mention here, under this ANEI platform, we already had a webinar, learning webinar on communication, which was very, very well described, and it was very, very nice discussion in the month of June. Whoever did not join, kindly go back and watch that video where so beautifully it was mentioned all the standardized tool what to use for effective communications. Ineffective communication can act as a disaster if we are not careful enough. Just to say an example, I hope everybody is aware. If a order comes as 14 units of human ectropid insulin to administer, and if it is misheard as a 40 units of human ectropid, whereas 14 is 14 and 40 is 40. So there is huge difference. And if we do not follow the standard communication tool and process, then it will definitely cause a disaster, and we might lose the patient, as Thankum ma'am rightly said, that hypoglycemia can kill a patient. So to have effective communication, as I mentioned, we have lots of tools like verbal order policy can be there, read back is there, so which can be followed, and we can prevent communication error leading to patient safety events. Another one is unaddressed previous hypoglycemia. A patient might experience hypoglycemia again and again. It might be patient might go home, in a healthy status. At home, maybe patient had already experienced a hypoglycemia. Patient came to hospital. Maybe in the previous hospitalization, patient already had hypoglycemia. However, if we do not address this kind of issues, if our history taking is not proper, if we do not do medication reconciliation in a proper way, then again, this might lead to serious events, which we are going to talk about hypoglycemia unawareness, which will not even give us any clue that patient is suffering from hypoglycemia, and we'll lose the patients. Another one is insulinomas, which can be categorized as endogenous cause. It is nothing but it is a hyperfunctioning islet cell tumors of pancreas, which is associated with increased insulin secretion. This can be life-threatening because this will cause mainly morning hypoglycemia, fasting morning hypoglycemia. And even if patient is not diagnosed with insulinomas, when patient is suffering from hypoglycemia again and again, there is recurrent hypoglycemia, we need to consider this cause as well. So here we have already discussed about all the causes. I hope we all will be knowing about the causes as well as in the comment box also. Thank you so much for contribution. As we have already learned the causes and the types, why we have to discuss so much about severe hypoglycemia? Because there are risk associated with it. So let us see what are the risk associated. Definitely, it is a shock. I'm not going to explain the pathophysiology shock. However, whenever severe hypoglycemia occurs in our body, it stimulates endothelial dysfunction, which can cause vasodilation and which will lead to decrease in blood pressure. Decreased blood pressure tend to again low blood circulation to vital organs like brain, heart, and kidneys, which is again nothing but shock. Another is associated with arrhythmias. Function impairment, as I have already mentioned, this all will cause directly or indirectly increased cost of medical care for patient and the patient family. And finally, there will be increased length of stay in the hospital stay for longer duration with us, and all unanticipated that hospital as well as the community setup. And I think you all will agree with me whenever we have seen no, nowhere to be mentioned that glycemia is the cause of death. However, it is marker of underlying disease rather than a cause of fatality. So, as all of us is agreeing that hypoglycemia can cause fatal condition as an underlying disease. Now we are in a stage that we have already learned the associated risk also. This is the way how cardiac health will get impaired. Hypoglycemia will induce inflammation by stimulating the release of CRP, IL-6, and vascular endothelial growth factor. It can also increase the activation of platelet, factor VIII, and neutrophil. And it will stimulate the sympathoadrenal response, which will lead to cardiac workload increase, which is why patient will have cardiac arrhythmias and all the other risk factors associated with cardiovascular system. What we were talking about hypoglycemia unawareness is whenever patient is suffering from recurrent hypoglycemia and we are not able to address that issue, so what will happen is there will be diminished autonomic response to hypoglycemia. Brain will not be able to sense all the hypoglycemia sign and symptoms. We have all learned the hypoglycemia sign and symptom, but this is such a dangerous stage we will reach that patient will not exhibit any sign and symptoms of hypoglycemia. There will be no sweating, there will be no palpitation, there will be no tremor. So until and unless we check the blood sugar level in POCT meter, we will not be able to know that patient is suffering from hypoglycemia. I hope all of us who has joined today or all of us will not want our patient to go to this stage. Before reaching to this stage, we want to prevent the hypoglycemia so that we can take care of the patient. Now, main part of today's discussion, how to prevent it and how we are going to manage it. So again, want to mention here that we have taken all the strategies, all the guidelines from Patient Safety Foundation USA. So if anybody is interested, you can go and read the entire document for better understanding and learning. So it guideline says that there should be a standardized protocol for prevention of hypoglycemia, which can be including of inclusion of blood sugar monitoring protocol can be developed. I hope many of the hospital, almost all the hospital might be already having it. We can also create hypoglycemia task force, or you can name it as a diabetic team, which can be comprised of endocrinologist or the physician, diabetic nurse, a clinical pharmacologist, definitely, pharmacy team, diabetic educator, dietitian, and so on. We can add quality person so that this team can work on it in a hospital setup. And it can define many various protocols to prevent hypoglycemia and management of severe hypoglycemia. We can also think of standardization of patient and family education content. What we all understand and know that if same language is been spoken to patient and family, it has been very much useful for patient and family to understand better. If we have a standardized content, we can use it for display. We can even use it for both inpatient, outpatient, as well as community. So the standard patient and family education can be created and can be circulated for better understanding. In coming slides, Bijaya ma'am is going to talk about this in details. Another important topic is in-service education. We can name it diabetic certification course. And what we are doing today, that learning webinars, these are also very much helpful for, creating the awareness of prevention of hypoglycemia. This also ma'am is going to discuss in upcoming slides. As Thangam ma'am rightly said, we need to know the patient stories. We need to know our patient, what they are exhibiting, what are the signs and symptoms they exhibit. Like pain assessment, hypoglycemia can be also a subjective assessment, which patient will say that I'm not feeling well or I'm having this kind of symptoms. So if we explore different kind of patient stories, these patient stories, the link, I think if we have time, then we can play the video in the later stage. This patient stories is there in the Patient Safety Foundation guideline. You can go and watch this if we do not have time in the end stage. We can also think of development of early warning signs for hypoglycemia for creating awareness in the institution. If we develop these early warning signs, It is not only for the clinical person working in the hospital. It can be for, if we develop in a very easy understanding words, it can be also used by non-clinical staff. Because when patient is waiting for consultation in a OPD, maybe patient is entering to the hospital by work, even a security person, even a housekeeping person, if we design in such a way that easy understanding for others, everybody will be aware that what all are the hypoglycemia signs and symptoms, and everyone can contribute to these patient safety events. We can also have policy for community awareness program. Community is also very, very important, because nowadays I am pretty sure that every one of us know that in our family, 1 or 2 person is suffering from diabetes. So it is very, very important to spread the awareness in community. We can select some specific date like World Diabetes Day, World Health Day, what else? And we can go out, we can reach to community, even we can reach to few specific group. Like I was thinking, the traffic police who are showing us the doing the traffic control, they have to stand in the sunlight and all, they might be also having hypoglycemia sometimes. So if we spread the awareness, we are not only thinking for our patient, we are also thinking for community safety program. So we can have this kind of signage like, do not let hypoglycemia control your life, or stop hypoglycemia, so that everybody becomes sensitive. We can also display the hypoglycemia sign and symptoms, or it can be developed as per the hospital or institution guideline, some early warning signs. Continuing with the prevention strategy, another very good guideline which I have got is that customization of the food tray for patients who are diabetic. We have seen similar kind of food trolley which has been carried for distributing the food for the patients. If we can customize this food tray, or if we can have some tag in patient food tray, or maybe color coded, that patients who are breaking the NPO, or patients who are diagnosed already with diabetes, then the steward who is serving the plate to the patients also will be aware that which patient should get the food first. And if we have this kind of system, then also we'll be better controlling the insulin administration time and the food time of the patients. So these are the strategies which our guideline says. Continuation of the blood sugar monitoring protocol. I hope every hospital has this protocol. We might talk about 7-point blood sugar check. We might talk about 6-point blood sugar check. Whatever is the blood sugar check protocol we're adopting, however, it need to be standardized, and so that we do not have that cause which we have seen, that failure to monitor blood sugar level. So we do not want to lead to that clause. So we want to have a blood sugar monitoring protocol as well. Continuing with other prevention and management of hypoglycemia, we can have development of NBM breaking protocol. I was going through an article which is published in Nursing Times journal, which says that we need to have, if we need to see that how much a patient is on NBM, maybe it is for preoperative stage, or is it exceeding the timing of the NPM. So can we think of some alternative, maybe IV fluid, and we need to also assess that patient should not go to dehydration, and we need to be very, very careful when patient is diabetic and they are in NBM stage. So these are the things. Various guideline has says many things, and we can also think that how much is the time that time should be followed when NPO is over. Doctor has advised that NBM is over, we can start giving clear liquid or whatever it is. So how much time should the food and beverage department should take to supply to the patient area? Another one is dosing guidelines creation. I hope every one of us have this insulin sliding scale, which is becoming very, very easy reference for us whenever we check the blood sugar level. And as per the blood sugar level, we can give or we can decide the insulin as per the types of insulin. Now we have already discussed that what all we can do. Still, patient might be having hypoglycemia. So now how to manage the hypoglycemia? We cannot waste time here. So if we can have hypoglycemia algorithm, again, who all already are following hypoglycemia algorithm, you can put in the comment box, or which guideline you follow, you can also put that. So hypoglycemia algorithm is a very standard guidelines which tell us step by step. Suppose this much blood sugar is for diabetic patient, what to do. If non-diabetic patient had this much blood sugar level in the POCT meter, what next? If patient is having IV line and patient is not having IV line, so step by step guideline can be created, which is again very easy reference for both doctors and the nurses who are in the floors, and with no wasting time we can manage the hypoglycemia. We all agree that audit is always for improvement. So after implementation of all the guidelines, it is what to check the process, that is it happening or not. So we can have regular audit for identifying some contributing factors which can lead to hypoglycemia, which outcome will be like we can have lots of learning points from the audit. Another one, we can have regular process check. Suppose any patient had hypoglycemia in the bedside, the patient got hypoglycemia, was it preventable? If we can check on this process, and there will be again learning out of the hypoglycemia or the incidents, which can be much helpful for managing a hypoglycemia in the future. Another protocol can be developed, which is similar to hypoglycemia algorithm. How much carbohydrate to administer, how much dextrose to administer, it can be mentioned in the hypoglycemia algorithm itself, so that it become very much easy for us to manage hypoglycemia in inpatient. Thangam ma'am, anything you want to point it here, and any more experience, or you want to add your valuable points, ma'am?
Thank you, Karishma. We are doing very well. Again, I will only tell the same things, that whenever you have, standing orders, you have sliding scales, do not forget to look at the patient. How is
Yes.
this patient doing? This is very important. Just following blindly the sliding scale is no use to the patient, especially when such smart nurses are at the bedside. It can happen with layperson, being the attendant, they did not know, and then they can, give the insulin without thinking. Okay. So a lot of good, inputs coming from the participants. I'm very happy to see that, because that would mean that you are paying attention to all the discussion and you are contributing to that. So great. So here I just wanted to talk about, the insulin and the mealtime. So I think Karishma already mentioned whether we can identify the food tray of the patient. Now, sometimes maybe you can't identify the food tray. So we used to have, when I was working in Fortis, we used to have this problem. There is mismatch between insulin being given and the food being served. So if the time gap is not right based on the insulin that you are using, very important to educate yourself about the different types of insulin and the onset. When does that insulin start working? As a assigned nurse, you must have this knowledge, so that you know that how soon the patient should be having the meal. So what we did long time ago was that, we on the patient information board, we put some signage, or we wrote D, I don't remember. We kind of identified the patients on the board, that these patients are diabetic. Okay. So when the FNB comes to the tray, they will look at the board and they will also double check that how many patients are diabetic. You know, because they are asking the nurses came to know that the food tray has come. Now they can decide to give the insulin. Now, very important that the nurses must go back and check, have they started eating, or are they still, waiting around, not eating, and not liking the food. So one meal round is very important. Nutrition is probably the most important factor for any person who is in the hospital for healing and going home. And for diabetes, what they eat and what they don't eat matters a lot. So how will we know as nurses that how is my patient's hydration and nutrition? Only if you get closer to what they are eating. So I would practically advise everyone, get to know your patient. Please do go and check that how much the patient had eaten. Don't leave it to the F&B, they will give the tray, they will come back and take the tray. Maybe in majority of the patients, it may not matter, but in vulnerable patients, it could make a lot of difference to their, prognosis. It can lead to complications. So, lot of, good things are being discussed in the class here. And you need to think also to be creative. Sometimes you cannot do everything that comes as an idea because you are working in a different setup. So you may think about, doing something that is doable, which is cost effective. Pinaki is writing food tray with color code for diabetic patient is established in Apollo hospitals. Great, very nice. But in case if you cannot invest in color coded thing, you may come up with something else, right? Maybe a simple communication between the person who is bringing the food tray and the nurse who is there in the nursing station. Even that will work. So communication again is coming up. No, for everything there is communication. How you communicate to your doctor. What are you doing when you are talking to the doctor? So I will still park the story. Karishma, I'm going to still park the story. I will tell the story in the end. Okay.
Yes, yes, ma'am. Okay. Ma'am, very rightly said, the food intake, as I said, what, how much, and when patient is eating, it is very, very important. And as nurses, we need to also see a meal round. Very nice, ma'am, meal round. We can also see how much patient can finish, 1/3, 1/4, and it can give us a very, very good idea that how can we go ahead with that prescribed units of insulin or not as per the patient food intake. So another one is a campaign can be initiated to spread the awareness. So I was going through different celebrities and I found that Nick Jonas, I think everybody is aware about that. He was also diagnosed in his younger age as a diabetes, and he has started a campaign of spreading the awareness of the hypoglycemia sign and symptoms. Like this, if we can initiate some campaign inside or outside both hospital and community, then that sensitivity gets spread and everybody will be eager to learn and to know that what are the sign and symptoms I need to look for myself. Do I have hypoglycemia sign and symptoms or not? So moving ahead, these are the examples which we have already discussed. So moving ahead, I want to hand over to Ma'am Bijaya for rest of the prevention and management of severe hypoglycemia. Over to you, ma'am.
Thank you, Karishma. Now let's continue with the prevention and management of severe hypoglycemia again. Okay, in the hospital, what we can do is we can give a ward. Okay, in a particular nursing unit or in a particular ward or in a particular department, the nurses can be awarded for the good cats or it can be given for their mates, or they can even give the scorecard. And depending on that, depending on the performance, the nurses can be given awards periodically. Then the nurse leaders or the in charge of that particular unit or that particular hospital or that particular ward can create also culture of incident reporting. This is very important because sometimes when we do scold the nurses, they will hide the problems, they will hide the incident. So we should motivate them to make sure that they will enter or they will document or raise the incidents of severe hypoglycemia. Then another point which we need to remember is there are discussions which are done periodically regarding the hypoglycemia at the higher authorities. But sometimes higher authorities, like for example, in the hospital leadership board, in the departmental meetings, or it can be in the quality and safety meeting. But sometimes those periodic discussions which are done regarding the severe issues of severe hypoglycemia can also be discussed even in the ward to all the staff when they are present, maybe during the end of the what you call it, duty timing, or it can be periodically. You can still have the discussion so that they can control or they can minimize the severe hypoglycemia. Then we also have in-service education, which we can do it. Then there are some courses which we, like diabetes certification courses, which they can, even the staff can also do it. And then periodic training of different types of insulin can be explained. Because now, for example, in some of the hospitals, the trade name and the pharmacological name doesn't match. So like suppose if I am from this side, from the northeast, sometimes the trade name, if I do not know the pharmacological name, I may not know the trade name. So in that case, when you explain, please do explain about the trade name and the pharmacological name also. So it is better to learn the pharmacological name, and then you also explain about the types, that is whether it's a rapid acting, whether it's a short acting, whether it's an intermediate, and then whether it's a long acting also. Those training has to be given periodically, even for the new staff, even for the students also can give the training when they are even in the student period. Then even during the clinical handover process, we do make sure that, or we should make sure that every patient who are diabetes should be handed over. Sometimes if you know that the patient who is a diabetes is going to shift in the ward in the second half, maybe around 1 o'clock, in that time you need to assist, or you need to check whether the patient had got the insulin, or the patient had already eaten the food and then it was already transferred. Because sometimes we miss, like we are in a hurry to transfer the patient to the another ward. In that case, what happened? This patient who are diabetes were not given the food, neither the insulin. So in that case, sometimes the patient used to get hypoglycemic attack, which I have already experienced it. So we need to explain it. Even when you have any procedure, for example, the patient went for the what do you call that, ultrasound of the abdomen. So the patient may have been uh, fasting. So in that case, you need to explain when did the patient went, or when did the patient fast. That you also need to be explained so that we can treat as early as possible. Then the next one is the medication reconciliation. So here, basically, what is that is, like when I suppose I am a patient who is a diabetes. Okay, I have been in treatment in Guwahati for so many years. Now I went to Apollo Chennai to get the treatment. So what do I tell is, I tell the doctor will tell that this is the this one medications which are there. But I also need to explain that these are the medication which I am taking at present. The doctor also has to compare whether it is a new drug, if it has to be given, whether it is the same drug to be given, or it has to be compared, so that they will not give excess insulin, or they will not give excess oral hypoglycemic agent to the patient. So this is also very important to compare it. Then the next one is the types of insulin, which I have already explained. So please do explain if it is a new staff, or if it is a student nurse coming to the ward to do the procedure, it has to be explained, even the peak hour, the duration also to be explained. Because when you do know this duration and the peak hours, it is very easy to minimize the hypoglycemic attack, which can be even the severe one. The next one we have is the best practice, which are taken from the evidence-based practice. So here, basically, there are 3 points which is written, but I will explain it in very simple terms. The first one is real-time analysis. So basically, what they used to do, the pharmacy people, they will do the surveillance. Within this 48 hours, once a hypoglycemic attack occurs in a particular ward, the patient, the pharmacist people, the pharmacists will come in the ward, then they will try to identify where and when this events occurs, but they will not state why it is done. And then the secondary is, we need to review the medicine inventories in the hospital. For example, I think, please add how many of you have in the hospital whether the glucon-D powder is available in the pharmacy or not, or even the sugar packet or the sugar sachets. Okay, sometimes we need to make sure that this sugar or the glucon-D powder or injection dextrose can be even available in the hospital, or it can be in the pharmacy, or it can be even available in the ward. So sometimes when you have this hypoglycemic attack, in that case, you can give you can start with this treatment. Then the next one is the quality check for the point of care testing equipments, which Karishma will be explaining in detail related to this. So I hand over to Karishma again.
Thank you so much for ma'am for sharing all these things. Now, discussing about the quality check of point of care blood glucose testing glucometers. I hope again many of you already practicing this. So it depends on the manufacturer guidelines or what company glucometer we are using. So what we do, we need to understand that my glucometer in the unit is working fine or not, or what is the quality control. So there will be Can you kindly mute? Yeah,
mute.
so there will be two control solution, one for lower ends and one for higher ends, and the standard range will be given by the manufacturer guidelines. So what we can do is, as per the hospital guidelines, we can check the glucometer with the strip with these solutions to understand that it will show which results. If it is within the range, that means we are very happy that our glucometer is working fine. If it is not within the range, we need to escalate this matter to the concerned authority. So another one which we can do for checking, quality checking for positive blood glucose glucometer is, we can collect the blood sample from the same patient, which one sample we'll send to laboratory for testing for blood glucose, and another sample we can check in the POCT meter. So we need to compare the value which is coming in with both the results, and if the results are okay, I'll tell you the difference, that if it is not within the range, and again we need to escalate it. So I have gone through literature from American Association of Diabetes and as well as ISO. They have said that the range is acceptable if it is showing the difference between 15% to 20%. So if it is not within this range, then we need to escalate. And we can also check on compliance on this glucometer quality check or not. Why it is very much important to do is, we have seen, as Thangam ma'am has mentioned, that we need to look at the patient face. Patient might show the range in the lower level in the POCT meter. However, what the patient is manifesting, what all are the signs the patient is having. Because the glucose strip functionability depends on its storage, exposure to light, humidity, and if these are not taken care, it can decrease their stability by 14 days. And glucometer also needs coding, which has to be done by company persons. So if it is not done, again, it will not show us the correct value. And the POCT meter, whenever we check from capillary blood sugar level, it might be affected by hypotension, because whenever patient is suffering from hypotension, there is decreased tissue perfusion, which might also alter the blood sugar level. So this process need to be done to ensure that our POCT glucometers are functioning well. And we have come across, have you come across the value is different, your glucometer is showing completely different, or sometimes patient might have some sensor in their own, from their own self, it is also another value it is coming, and laboratory also showing another value. What do we do in that case? So if you can share in the chat box, it will be helpful for learning. Hand overing to Bijaya ma'am again for continuing the best practices. Bijaya ma'am.
You continue, Karishma. Maybe Bijaya.
Now,
Okay.
I would like to give one example. Like
Okay.
me being in the teaching profession, we used to take the students in the community to check the glucose, blood sugar in the community. So what happened is, sometimes we have our own glucometer, but these students, when they found that the strips is not there, so they used to buy randomly one. And then I was so surprised to see that without seeing the code of the glucometer strip, they bought the another one, and it was showing very different range. So that is what we have to remember, that when we instruct the student to buy the glucometer, suppose the strip, okay, if it is over from the cholesterol, please do make sure that they buy the correct strips and it is put with the correct glucometer. Okay, now continuation of that, we also have Karishma, okay, the next point also. These points I think we already have discussed, ma'am. Thangam ma'am also had discussed, and then ma'am Karishma also have discussed. So here I would like to explain only this Somogi effect. So this Somogi effect is very important. Sometimes when you have a patient, okay, for example, the patient didn't have the food properly, and then the insulin was given for the dinner. So what happened? Like when you check the bedtime sugar would be normal. But suddenly we have something known as the Somogi effect, where in the dawn, or in the not in the dawn, in the early morning, somewhere 1 o'clock to 3, almost till 4 o'clock, or the dawn or the early morning, the blood sugar drops rapidly. Okay, in that, when suppose the patient didn't have the food properly, and then you gave the insulin which is on the higher dose. So what happened is the blood sugar drops rapidly, and in that case, what happened? The patient will, in order to compensate this hypoglycemia, the body hormones will be released, like your adrenaline, your corticosteroid, and even your growth hormone glucagon will be released, where they will try to make sure that gluconeogenesis, or the increased production of glucose, will be released. That's why in the early morning, when you check the blood sugar, again the blood sugar is elevated. So we need to see that the amount of the food the patient is taking, the dose of the insulin has to be coincide. So the remaining, I think ma'am has explained, so I'm not going to go further. Now, the next slide, please. So there are some of the best practice which are already mentioned from the Milligan et al., which was done in 2014. So here what is mentioned is there is something, we have the insulin order set. So in all the points, what you have to just remember is any insulin order, if it is written depending on the amount of the food the patient has taken, the physician order should be changed. Even though if it's written for the night, usually in the morning when they come for rounds, the doctor used to write morning, evening, night. They used to write the orders in some of the hospital. So in that case, you have to make sure that if the blood glucose is low, please do hold down the physician order, report it, and give it. Because this is the time when, if you give wrongly at 2 o'clock in the morning, or at 4 o'clock in early morning AM, sometimes we need to check the blood sugar, and then correction has to be done. So in order to prevent this, we have to do it. So, and the third point is, any patient, if there is a hypoglycemic, which can be in level 1, level 2, or hyperglycemic, need to be informed. And any diabetes management team, we need to make sure that the pharmacist and the endocrinologist should be there, along with the dietitian or the nutritionist, which is available in the hospital, can also be required. But at the end, what is there is, we need to have early recognition and management of mild hypoglycemia, which can further prevent the severe hypoglycemia. Now, the next one is the community awareness for the hypoglycemia. Now, Karishma has already explained it, but this is regarding the hospital. So when a patient is a diabetes admitted in the ICU, or it can be in the ward, you need to have a structured discharge plan. The first point you should remember is the identification of the caregiver. This is very important. You may have one important caregiver, or you can have one second important caregiver, because we need to identify to whom are we going to explain it. The second is, you need also to explain the self-monitoring of the blood glucose level. Then third one is home blood glucose goals. How much are they supposed to maintain? Then danger signs and symptoms is very important, which we have already mentioned it. Then prevention and management of hyperglycemic and hypoglycemic, which I will discuss a little later. Then education on diet and exercise. So education on diet and exercise, like for me as an experience from the student side, when we tell about diabetes diets, they have written all the diets which are available in the foreign countries, because we are using the Lippincott manual, what is it called? Lippincott, Black and Joyce, all the foreign books in the medical healthcare. So this, you have to check on it, whether the students or the teacher who is it should focus on the student, that they should encourage the student to write the food which is available in the Indian setting, which is locally available in the Indian setting. And then the exercise also I will discuss little detail in the next slide. Then education on the oral hypoglycemic agent and demonstration regarding the insulin administration should also be explained. Now, I want to share a small example before Ma'am Thankam share it. So here, insulin administration, the site of insulin administration is very important. I have my own uncle who was diabetes for almost 5 years, but hardly I used to go and meet him. But one day when he called me to give the insulin, I gave on the upper arm, okay? But the uncle was telling, why don't you give in the forearm where you give the testing for the antibiotic, where you do the skin test for the antibiotic. Every day he was getting over there. So he's telling me, why are you giving on the upper arm but not in the forearm, where the antibiotic testing, that area used to be there? Then I was so surprised. Then I asked him, who used to give Then he told me the pharmacist, there used to be one person from the pharmacy. He used to come every day. Then I was so shocked. Then I explained about the sites where it is to be given. Then he was very happy. So that is very important regarding the site. The changing of the areas also should be explained. And then proper use and disposal of the needles and the syringe also has to explain. Now I want to explain one very short one, which we call it as the rule of the 15 to treat the hypoglycemic in the hospital. So in the picture, what is written on the right side, you can see that you have to eat or drink 15 grams of carbohydrates. So this can be done when you have moderate as well as mild hypoglycemia. So when I tell 15-gram carbs, the layman will not be able to understand because it is something jargon. So you can just tell that you have to take 1 bara chamas of sugar. You have to take immediately, then the blood sugar will increase. Okay. So once you take that 15 gram or 1 tablespoon of plain sugar, then you can wait for 15 minutes, check the blood, and then if it is less than 70 milligram, then you can again repeat step number 1 to 4. So this is only, or this can be done only when you have patients who are in the mild as well as the moderate hypoglycemia. But if it is a severe, obviously we have to start with the intravenous injection, which is with 25% dextrose sugar or anything which is available. Okay, ma'am, would you like to share something on this?
I think you are explaining extremely well. The right side is called as 15 by 15 rule. That means 15 gram of carbohydrate and wait 15 minutes. Do the sugar, give it again. One bottom line is just look at the patient's consciousness level. How conscious is the patient, you know? So based on that, your urgency of treatment, I was just asking someone that, you know, is it part of your early warning score? Is blood sugar part of that score? You know, while you were discussing about it, just a thought came to me, you know, if that becomes the one of the early warning score component, if you modify, anyway, everybody is using modified early warning score. So why can't sugar be one part of it so that, you know, the patient gets the attention at the right time? So I really liked when Vijaya told, just give 1 bada chammach sugar, you know, and advise them to carry sugar sachet with them rather than chocolate, you know. They may not be in a position to eat the chocolate, but better put the sugar in their mouth because each patient will know. The most safest thing is to have access to plain sugar. So in the hospital also, do you keep sachet in all the nursing stations so that do you have a standard protocol? You know, everybody tends to think that every patient needs dextrose IV. It is not necessary. If you are able to catch the patient on time, you can give, you know, patient is conscious, just give him sugar, he can eat, or you can just put it in the water and you can give, you know. Does anyone know that is plain sugar better or glucose D better? So how much 1 bada chammach of glucose D will have sugar? So now you know, you should go back and check glucose D, 1 big chammach, is it 15 gram of, you know, sugar or it is less, you know. So 15 gram is what is the thumb rule, and then wait for 15 minutes, check the sugar. So it's not rocket science, but it's very important to look at the patient. Yeah. Yes. Thanks, Bijaya. People are already asking. Seems to be better. Good to hear, Pinaki, but when confirm that 1 big chammach of glucose D, will it have 15 gram of sugar? That's all we need to check. Okay, great. So Karishma already shared, I think, the form for certificate. A lot of people are waiting for that. Great. Shall we continue? I think we are almost there, going to close, correct? Yeah.
Oh, I hope everyone is not having hypoglycemic now.
No, no,
Because we
no.
are taking a long now
Yeah.
to continue. Like, even though if we have given the discharge plan, what is the main responsibility of the nurse is to see whether the patient understood the concept. Now we will be telling blah blah blah, and then we are not evaluating the patient. That should not be there. You need to ask how far they have understood, how far they are, they can tell you. So the tips back to ensure should be there. Now, in the next slide is what we wanted to explain is regarding the exercise. Now, there are some people who are diabetic, who wanted to go for aerobic
Guys,
exercise,
please
who wanted to go for
mute yourself.
Okay, there are some of the people or individuals who wanted to go for who are diabetes, but they are involved in sports, or they wanted to go for exercise. So here, what we need to explain is we need to explain how much of aerobic and anaerobic exercise is involved. We have to ask them whether they have, like for them, the main thing is, even though if they are having aerobic, please do, or anaerobic exercise, please make sure that how much is the tolerance, whether they had their breakfast, a light breakfast, and if they want to go for walking, because most of them this diabetes patient, what they used to do is they do not have the breakfast, they go for the walking, then come back. That is what I have experienced in many of the diabetes patients. So please make sure that they have a light breakfast and then they go for diabetes. But you also have to see how much the patient can tolerate also. Then the duration of the exercise, not only the duration, but even the weather. Sometimes if it is very hot, sometimes they may feel very tired, and then the hypoglycemic also may be landed along with the dehydration. Then you also must make sure that explain that you have to risk of the injury or the morbidity to self if the patient becomes hypoglycemic. So this is what I want to say. So any patient who are diabetes and who are in the sports, special consideration has to be taken into it. So I hand over to Karishma once again.
Thank you, ma'am, for detailing the discussion of this. Now, ma'am, I'm not able to change the slide.
Just go back once and again forward. You can stop sharing and share once again. How many more slides are there?
Yes, very few, ma'am.
Ma'am, only 2 slides are there.
Okay.
Yes, only 2
They're
slides.
already 8:17. We should wrap up. Yeah.
Yes, sure, ma'am. So, is it
Now go to the slide and put it on slideshow.
Yeah. So as we are coming to an end of our discussion, to summary, so the question comes now, is hypoglycemia preventable? Are we capable to prevent hypoglycemia? Or is severe hypoglycemia preventable? As I said in one of the slide that despite of taking all the measures, maybe patient will have hypoglycemia. However, it should not be going to the severe hypoglycemia, or you should not go to a stage of recurrent hypoglycemia where we'll not be able to even know the signs and symptoms and we'll lose the patients. To summarize, we have discussed various important points today. And Thangam ma'am has given us the idea to share some success stories. So, is anybody in the audience will to know that who is she? The lady with the crown?
Maybe no, because they all seems to be pretty young people. They would say, "Oh, I was not even born then." I don't know. So better you
Okay.
tell them the
So
story.
she is Miss Nicole Johnson, who won the crown of Miss America 1999. She is the first one to own this title with having diabetes, and she was diagnosed diabetes long back, and she was on insulin pump from 1998, where she also won Miss Virginia. Now she is very much active as a diabetic, she used to contribute for diabetic research. She is associated with American Diabetic Association. So if she can manage her diabetes, and she can control, there is no sign and symptoms of hypoglycemia. So I just searched out of the interest any other people are there. So cricket fan, I think you all know, he was also diagnosed with diabetes and maintaining a good lifestyle. I did not know about this lady. I think again movie fan, you all know. So do you know anybody? I already mentioned Nick Jonas, who was diagnosed with diabetes, and they could manage the diabetes and not having hypoglycemia events. So there are success stories. That means we can prevent hypoglycemia if we manage in a proper manner. To summarize, as we have seen, the severe hypoglycemia can lead to a fatal condition like death of the patient. So it is very, very important to have a prevention and management protocol which should be adopted and implemented in each healthcare settings. Most effort we should, invest where it is, as we have discussed, mostly prevention. Prevention is always better than cure. We need to work on the patient education, teach back, which was again we have learned through learning webinars under any platform. Please go back to any website, whoever is not till now, and check all the YouTube videos where these all are already mentioned. Like Bijaya ma'am has mentioned about incident reporting culture. These all things has been already explained in detail, a very, very beautiful way. So we can have dietary and exercise regimen which can be adjusted appropriately. So these are the ways, and whatever we have discussed today as a preventive strategy, if we can adopt everything and make a bundle, then I think we will be able to prevent hypoglycemia, and there will be no patient safety events leading happening because of hypoglycemia. So that's all we these are the reference which we have collect all the information for severe hypoglycemia, major references, major contribution from Patient Safety Foundation guidelines. So thank you so much for patient listening, and thank you so much for joining in such a huge numbers and all the contribution in the chat box, all contribution for learning. We learn from each other. Thank you so much. Now over to Ma'am Thangam.
Thank you, Karishma and Bijaya. That was a very interesting insight into people may think it's very common, but it is as complicated, and you can complicated yet at the same time very simple to prevent. Maybe we can stop sharing, Karishma. Thank you.
Yes,
So
yes, ma'am.
I think there was one question was about the glucon D. So glucon D typically can have 12 to 15 grams of sugar, glucose in it in 1 tablespoon, but based on the manufacturer. So whatever glucon D you are keeping in your hospital, it should be very clear to the nurse. So just now Amita shared that 100 gram of glucon D will have 44 grams of sugar. So that means it is not equal to 1 gram of glucon D is not equal to 1 gram of sugar. So the some glucon Ds are 1 gram is equal to 1 teaspoon, 1 gram is equal to 1 gram of sugar. So glucon D 100 gram will contain 44 gram. That means it's not 1:1. So you need to now figure out how much of teaspoon will be 15 gram. How many teaspoons you need to. So you have to make that very clear to your people in the hospital. Whether you are going to give sugar, glucon D can be given very easily because it will dilute in the water very quickly. Sugar, it will take a little bit more time. But if the patient is conscious, you can always give them sugar. I have one question. Can you harm a patient in case you give more glucon D or more sugar? Can you really harm a patient who is experiencing hypoglycemia? Answer is no. You cannot harm a patient. So you don't need to be afraid, my God, I give 1.5 tablespoon of sugar. What am I going to do? Nothing like that. You cannot kill a patient unless their blood sugar will, shoot very high. 300, 350, 400, that is when the issues will happen. So we need to explain to our nurses, it's okay. You have glucon D, write that in case some patient is having hypoglycemic symptoms, immediately they should be able to give it even before they inform the doctor. I have had cases where patient is very clearly experiencing hypoglycemia and my nurse is very busy informing the doctor. Hello, doctor, this patient is having hypoglycemia. This patient is sweating. This patient. So obviously the doctor will call me and say, please teach your nurses to do the first 1, 2, 3 before they call. So I would only request, just be diligent and be aware what can be done. Extremely useful information, advanced information, basic information. I think you both have done justice to the topic. So there was one question that how to manage hypoglycemia at home. So I would always suggest that we should educate the patient, first of all, whether he's on oral hypoglycemic agent or whether he's on insulin. Okay. They may be taking 2, 3 oral medications. My mother was on 3 medications. Just monitoring her sugar, she's now back to 1 medicine. Okay. Her fasting blood sugar is about 148. You should also know the ranges. What does in India the endocrinologists say? What can it is better to have high sugar than tightly control the sugar. That is the overall recommendation. So last week she had 168. So I told my mother, go slow on mangoes. So this week I checked, it is 148. I said, perfect. Then she said, I need to bring it down to 120. I said, no, you don't have to bring it down. Just be okay. Didn't adjust any medication. And she also knows when she feels little low. I know I never could document any of her episodes like the way I had documented for myself. But I told her, in the night, if you feel low and you think that my sugar is going down, don't worry. Either you have your sugar or he always keeps biscuits. She likes to eat biscuit. So I think every patient will know their body better, but it's always advisable to keep plain sugar or if Glucon-D if they like it they can keep, because I tried Glucon-D at home, but nobody was eating. So finally it got expired and then we had to throw. So I thought better to have plain sugar. So at home, it is better to tell them that you can do everything and the diet better. The dietitian should be able to, maybe that's one thing that I would like to advise. Sometimes the dietitian, what they do is they tell the patient, give a list of things without asking the patient what is their pattern of eating. The person who never looked at, bread, and if you tell them 1 piece of bread in the morning, they will say, oh, 1 piece of bread would mean 2 chapatis for me. They have to know what is the amount of, the similar Indian food that they should have. So, yeah, someone said, that I'm just trying to read. Very informative, interesting. Thank you. And I'm trying to see, there was one thing that came. I just thought I missed it. When I am reading it, I like to, okay. All right. So, yes, please educate them. And those who are taking insulin, they really have to be taught. And I would always suggest start asking the patient to take his own insulin when they're in the hospital, so that you're not teaching them on the last day. They are not even paying attention. And also just keep a watch on your syringe that is available. U100, U50, U40. And if there is a mismatch, you can have a wrong insulin dosage. Today, there is no time. There are, patient harm stories because the nurse did not pay attention, had the wrong syringe. So it happened when I was in Fortis. So what I did, na rahegi bas to na bajegi basuri. So I eliminated one type of insulin, so the syringe completely, and we only got one type of regular insulin. We did not mix it up, so that I know even by mistake they won't do a mistake. So that is called administrative control or engineering control, where you eliminate the risk completely. So this is one of the longest sessions, so I think we should wrap it up. Thank you, Karishma and Bijaya. Fantastic session. And thanks a lot for all the people who came here in big numbers, and people are still there. 239. Please share the link once again. Let them copy it before I close the session. Thank you so much, everyone. And take care of your patients and take care of yourself. Thank you so much. If any one of you is also on insulin or anti-diabetics, I hope you have learned something to look after yourself also. Please do not fast for too long while you are on duty. Inform your colleagues and make sure that they are aware that you are diabetic. It's nothing to be ashamed of and nothing to be kept hidden. Otherwise, they will not know how to help you. If they are aware, they know they can help you because they know you are diabetic. So that's why you may be looking tired or you are behaving a little funny. It is possible. Okay. The link is shared. Please copy, take it on your browser. And so I'm going to close the session now. The certificates will be given in the next 24 hours to all the people who are, giving the, feedback. And tomorrow evening, Dr. Bijaya, please close the link. Yeah. And
yes, ma'am.
I will see you all again in September with early mobilization management. Another very interesting topic, unique one. Thank you. Yes, thank you. Even at home, you can use this knowledge. Fantastic. I'm really happy that you people benefited. So take care, Shabba khair, and good night. Bye-bye.
Thank you,
Thank you
ma'am.
so
Once
much,
again.
ma'am. Thank you to everyone. Thank you so much.
Thank you.